Hello and welcome back. This will be part 2 in our approach to vomiting and abdominal pain. Specifically, I'll be talking about pancreatitis, that is acute and recurrent pancreatitis. So, getting right into it, first, we'll be talking about localized abdominal pain due to acute pancreatitis. And I'll be covering the topics under the following headings. We'll understand the pathomechanisms that underlie acute pancreatitis. We'll try to understand the central role of intrapancreatic enzyme activation in the pathogenesis of acute pancreatitis. Uh, then we'll go ahead and understand the three common pathways that lead to such intrapancreatic enzyme activation. We'll understand the mechanisms of end organ damage that result in the clinical presentation that we are about to discuss. Then we'll go ahead and deduce the etiologies that may lead to such acute pancreatic inflammation. Then we'll try to understand the different clinical presentations related to end organ damage. In particular, we'll be talking about how the clinical presentations happen due to a systemic inflammatory response, vessel wall damage, and secondary hemorrhage, as well as due to fat necrosis. Then we'll go ahead and become aware of the facts that generally color the quote unquote color the evaluation of acute or recurrent pancreatitis, that is the exact base rates of various causes of pancreatitis. And then we'll understand the causes of increased serum amylase in cases where there is no pancreatitis. And finally, we'll end with a word on ERCP related pancreatitis just for completion. So, acute pancreatitis. The pathomechanisms that are related basically finally all converge upon one common mechanism, that is intrapancreatic enzyme activation. Now, the thing is that the lysosomal hydrolases that are present in the intracellular organelles also contain um, do not normally contain trypsin, and because of this, if there is lysosomal co-localization of trypsinogen, that results in cathepsin B, that is an enzyme mediated activation of trypsin, of trypsinogen to trypsin, and that trypsin then causes proteolysis and acinar cell injury. So this is the common mechanism behind all sorts of acute pancreatitis, and this is why I like to think of the pancreas as essentially a powder keg, ready to catch fire. So, like I said, the basic mechanism is always the same. Finally, trypsinogen will be converted into trypsin, and the more the trypsin activation that occurs, more further that will further activate trypsinogen to trypsin conversion. Now, this type of intrapancreatic trypsin activation is the result of three basic mechanisms, and these mechanisms include the first most important mechanism is the primary acinar cell damage. Uh, th- this is the first mechanism that is there. So what happens is there is direct injury to the acinar cells of the pancreas. Say this is the pancreatic duct, and these are the ductules, and these are your pancreatic acini. There is direct damage to these cells that are lining the acini. So there's direct damage due to any cause that we'll discuss. So that results in, like I just said, delivery of the proenzyme and hydrolases into the intracellular lysosomal compartment. So we know lysosomes are basically the organelles that contain the hydrolytic enzymes, uh, which are activated when there is significant reduction in pH within that organelle. Okay, so lysosomes, when they fuse with other intracellular vesicles, they get activated, and then they digest the contents of the vesicles. So that is how internalized material is digested within a cell. So here what happens is that within the acinar cell, the lysosomes fuse with the vesicles that contain the inactivated trypsinogen. So when that fusion occurs, the as we just discussed, cathepsin B converts trypsinogen to trypsin, and that starts off this entire process. So that is that. Now, the second thing is that there may be impaired intracellular transport without significant sinus cell injury. So that kind of intracellular transport would naturally result in abnormal fusion of lysosomes with these trypsinogen containing vesicles and abnormal trypsin activation. Now, so this is the second mechanism, that is impaired intracellular transport. Now, the third mechanism is pancreatic ischemia. Now, pancreatic ischemia uh, causes impaired intracellular transport because obviously intracellular transport requires ATP, and ATP requires oxygen supply. So if the partial pressure of oxygen within the pancreas falls, there is impaired intracellular transport. Now, importantly, when you have pancreatic ischemia, there is also abnormal fusion of lysosomes with these intracellular vesicles, and that causes further trypsin activation. Now, when you have such trypsin activation, there is damage to the parenchyma of the pancreas. Essentially, it gets digested away, and that in turn causes inflammation within the pancreas. Okay, and that results in leakage of fluid into the interstitium of the pancreas, resulting in something known as interstitial edema. Now, interstitial edema increases the partial pressure within the pancreas, the pressure within the interstitium of the pancreas. So, because of that, there is a decrease in venous outflow first, and if very significant, it can even impair capillary flow rates, although very rarely will it affect arterial flow rate, but that perpetuates your pancreatic ischemia. Now, additionally, interstitial pancreatic inflammation also through other mechanisms, that is through neutrophil mediated damage to acinar cells, or other also other induction of mitochondrial dysfunction, reactive oxygen species production, results in impaired intracellular transport. So again, once any of these three mechanisms starts is initiated, they eventually lead to one another, and this results in a positive feedback loop. Now, importantly, uh, the primary cause of your impaired intracellular transport are metabolic abnormalities, and there are two metabolic abnormalities that are particularly important clinically, that is hypertriglyceridemia and hypercalcemia. Okay, so increased serum calcium levels and triglyceride levels. Whereas direct acinar cell injury naturally occurs, can happen due to trauma, although that's not something that I see normally. It can happen due to drugs, which is actually relatively common in the setting in which in internal medicine, and due to infections. Now, additionally, an important point is that although uncommon, it can also happen with systemic autoimmune rheumatic disorders. Now, mesenteric ischemia, but either vasculitic or atherosclerotic, can directly cause pancreatic ischemia, and pancreatitis is a very well known complication of polyarteritis nodosa in particular. So, that is something that must be kept in mind. Now, once this kind of trypsin to trypsinogen activation has occurred, there is, initially this happens in a neutrophil dependent manner, but what happens is that the release of damage associated molecular patterns eventually results in extensive neutrophil. Sorry, I mean, initially it happens in a neutrophil independent manner, not dependent, and independent manner, and eventually, once there is extensive extensive damage, there is extensive neutrophil infiltration, and neutrophils themselves extracellularly activate trypsinogen to trypsin. Okay, so that is the second phase, and that is what we call intrapancreatic interstitial inflammation. Now, again, there is activation of intracellular and then extracellular trypsinogen. And finally, we have endocrine damage. So, as we discussed, endocrine damage is the result of three separate processes. One is the release of a large amount of inflammatory cytokines and the resultant systemic inflammatory response. Second is the release of the enzyme elastase, which then breaks down the vessel wall of nearby vessels, and this is what causes basically causes the local vascular complications. So this would include a splenic vein thrombosis, as the splenic vein is right behind the pancreas, and it includes the formation of aneurysms in branches of the blood vessels that supply the pancreas, and secondary bleeding from the aneurysms. And we'll be discussing this in the next discussion, in the next topic, that is the usage of that is the diagnosis of acute pancreatitis and its complications using radiology. So we'll be coming into the details of this there. Then Finally, there is a release of pancreatic lipase, which causes local fat necrosis, and sometimes, although rarely, this fat can get embolized into the blood vessels, and that causes systemic fat embolization. Okay. Now, before we go into the clinical presentation of pancreatitis, we need to discuss how what are the causes or the etiologies that result in acute pancreatitis, and compare and contrast that with recurrent acute pancreatitis. Okay, so we'll talk about it under the following five headings: trauma or mechanical damage, drugs, and autoimmune disorders. So as we've discussed, all of these would result in direct acinar cell damage. Then neoplasias, because neoplasias could block the pancreatic duct. That is how they would cause pancreatitis. And then metabolic, because these would impair intracellular, co-localization of trypsinogen contained vesicles with your the lysosomes within the cell. So let's talk about the causes. So the first most important cause is gallstones. Okay. Now, basically, gallstones, we'll come to the exact epidemiology, but these are along with alcohol the most common cause of acute pancreatitis. And again, indeed, they can cause recurrent acute pancreatitis. The second thing is occult disease of the pancreatic or biliary ductal system. Now, this classically is it's pancreatic divisum type B, where there is a failure of fusion of the minor and major ducts. We'll discuss that in the next the video on the topic. Okay, but uh, that is the okay. So that is the classical cause, but any other structural abnormality within the pancreas can also result in the same. Then we have blunt abdominal trauma and post ERCP pancreatitis. Now, recurrent pancreatitis can occur due to periampullary diverticulum formation and due to pancreas divisum and type C. And this is important to remember. It's not type C, it's type B. Okay. So then we have drugs. So drugs include obviously ethanol, alcohol, and some pancreaticogenic drugs, which we'll discuss. I remember with the mnemonic, move fast, which we'll come to just now. Then we have autoimmune disorders. So this includes autoimmune pancreatitis, which is divided into type 1 and type 2. But importantly, most autoimmune pancreatitis actually presents with chronic pancreatitis. So we'll be discussing this in more detail in chronic pancreatitis. Now, an important thing that one must remember is in case of thrombotic thrombocytopenic purpura, in addition to the classical pentad, that is the fever, CNS involvement, cardiovascular involvement, thrombocytopenia, and intravascular hemolytic anemia, we also end up having acute pancreatitis, and that is present in a significant minority of patients. Then we have neoplasias. Okay. Now, one important thing that one needs to consider is that systemic autoimmune rheumatic diseases also can cause pancreatitis. This is particularly the case with naturally Sjogren's syndrome, but primary more than secondary, because obviously there is an anti-epithelial immune response happening there. But it is also the case, very importantly, in systemic lupus erythematosus as well as in forms of vasculitis, particularly as I just discussed, polyarthritis nodosa, and also in case of inflammatory bowel disease. In case of IBD, the mechanisms that result in pancreatitis are multifold. They include, say in Crohn's disease, obstruction of the ampulla of Vater by a granuloma. They could be drug related. They could be related to primary sclerosing cholangitis due to secondary, carcinoma formation, all these. So there are multiple mechanisms that result in pancreatitis in a case patient with inflammatory bowel disease, and we've already actually discussed this, or rather we'll discuss this under the extra pancreatic or extra intestinal manifestations of IBD in a subsequent lecture. Now, in case of neoplasias, the most important neoplasia obviously is a carcinoma of the head of the pancreas, but also very importantly intraductal papillary mucinous neoplasias, so IPMNMs, and this is the characteristic classic presentation of IPNMs. Now, importantly, ampullary carcinoma, that is a duodenal ampullary carcinoma, and carcinoma, or rather a cholangiocarcinoma of the distal end of the common bile duct, can also obviously present with a similar presentation. Then We have metabolic causes. So among metabolic causes, we have hypertriglyceridemia, and this is typically attributed or considered to be a significant, significantly associated with pancreatitis when the serum triglyceride levels exceed 1000 milligram per deciliter, which, as and one would expect, is exceedingly high. This naturally most commonly occurs with genetic mutations that result in familiar hypertriglyceridemia, that is monogenic, and the most common cause of that is an ApoC2 mutation. Other causes are ApoC5 mutations, as we'll discuss in our disorders of lipoprotein metabolism. Now, just as a caveat, in cases of SLE related pancreatitis, there are certain things that need to be discussed. One is that more than 50% of SLE related pancreatitis occur within the first 2 years of disease presentation. So it is a classic initial presentation of pancreatitis, of which 22% of pancreatitis cases happen during the first presentation of the patient to or clinical presentation of the patient. So that is something that one needs to, keep in mind at the back of your mind when you're evaluating acute pancreatitis. Again, after that, of these patients in of SLE who develop pancreatitis, around 22% develop recurrent pancreatitis. So they have recurrent episodes. And finally, around 8 to 14% of these patients progress to developing chronic pancreatitis, which obviously we'll be talking about when we discuss an approach to significant but poorly localized abdominal pain. Okay. Now, direct, as I discussed, there are certain infections that can cause direct sentinel cell injury. So these are quite characteristic. One is cytomegalovirus, second is Coxsackie virus. Then we have mumps, enterovirus, and ecovirus. All are viruses, obviously, that are extremely epitheliotropic. And finally, we've got infection. So I use the mnemonic CME. Okay, continuous medical education. So that is CMV, Coxsackie virus, mumps, and E is enterovirus and ecovirus. Now, additionally, some parasitic infections that block the ampulla can also cause it, although it's a very uncommon presentation of these infections. Now, yeah, coming to the clinical presentations of these disorders. So, as I discussed, the clinical presentation of pancreatitis, excluding the abdominal pain, because we've already discussed how the abdominal pain presents. Just to reiterate, it is an acute onset or persistent, progressive, epigastric slash sometimes retinos and or retrosternal, moderate to severe dull aching or boring pain, okay, which radiates to the back of the patient, uh, and is obviously associated with significant worsening on, on feeding and even during the pre-oral phase of feeding. So that is the kind of abdominal pain which makes you think of pancreatitis. Now, in addition to that, there are certain clinical presentations that happen due to these three mechanisms. That is due to activation of the systemic inflammatory response, due to production of IL-6 particularly. Then hemorrhage because of elastase release into the parenchyma of the pancreas, and then fat necrosis. So in the central nervous system, because of systemic inflammatory response, you can get delirium and psychosis. Now, sometimes, although uncommonly, fat necrosis and fat embolization can also be responsible for the same. Now, uh, secondarily, so like I said, fat embolization can cause the same presentation. Now, second is hypertriglyceridemia. So now the issue is that whether pancreatitis is resulting in hypertriglyceridemia or hypertriglyceridemia is resulting in pancreatitis becomes a conundrum, and it's often very difficult to solve. But as we've discussed, usually more than 1000 milligram per deciliter is what is considered significant. At the very least, above 500 milligram per deciliter is significant. Then we have hyperglycemia because obviously the endocrine component of the pancreas is anatomically, located at the same place, so that can get affected. And hemorrhage or release of elastase into the blood and can cause adrenal hemorrhage, and this can precipitate an Addisonian crisis, resulting in obviously shock with normal anionic metabolic acidosis and your hyperkalemia. Then you can develop fat necrosis, which can result in the release of fatty acids into the blood, which then chelate calcium within the blood, and that causes a significant reduction in the serum calcium levels. So you can get hypocalcemia, and this is one of the causes of hypocalcemia, where PTH is overwhelmed, as we will be discussing our further discussion on calcium and phosphate metabolism subsequently. Then we have cardiovascular involvement. So we can develop, because of chronic significant systemic inflammatory response, you can develop shock, which is most commonly both hypovolemic and distributive. So hypovolemia would be the result of third spacing, that is loss of fluid due to capillary leak into the interstitium, as well as it would be due to hemorrhage. And distributive would be because the systemic inflammatory response is causing vasodilation in various parts of the cardiovascular system. Now, importantly, usually because of this, you also have a pericardial effusion and you have some non-specific STT changes causing some diagnostic confusion with acute myocardial infarction. And they can be difficult to differentiate, at least in the emergency department, especially if the patient is not very forthcoming with history. Obviously, in the right clinical context, things become quite apparent in most cases. Now, coming to the respiratory system, you can have, very importantly, pneumonia, particularly your left lower lobe pneumonia, secondary typically to atelectasis because of because of the pain that the patient is experiencing. Then, very importantly, this is one of the only organ involvements other outside of the lung that in itself can cause significant ARDS, that is acute respiratory distress syndrome. Then you get a pleural effusion, and naturally, this would be a left-sided pleural effusion because the tail of the pancreas extends more towards the left dome of the diaphragm, and obviously, this pleural effusion, it would likely be a exudative effusion and would contain, say, amylase and lipase levels higher than expected. Then there can also be mediastinal fluid accumulation. So this is all termed third spacing in radiologically, and we'll be discussing this under our discussion on the use of imaging in the diagnosis of pancreatitis. That is the next discussion in this series. Then respiratory system, uncommonly you can also get hemorrhage into the pleural space. So that is your pulmonary, that is called, that would be hemorrhagic pleural effusion, but this is an uncommon cause of pleural effusion in patients with pancreatitis. And then coming to the gastrointestinal tract, there is an association with peptic ulcer disease, and there can be erosive gastritis, but this is not like this is not a very clear-cut association. Then, very importantly, locally you can get portal and or splenic vein thrombosis, and because the short gastric veins. So, if this is the stomach, this is the lesser sac, this is the greater sac. The splenic vein is going like this behind the pancreas. That would be the pancreas. Okay, and it is going obviously to the spleen here. Uh, the short gastric veins that observe the greater curvature and dome of the stomach, they are actually tributaries of they drain into the splenic vein. So if there is a thrombosis within the splenic vein, that results in increased pressures in the short gastric veins, and that can cause variceal dilatation and bleeding there. So that is why upper gastrointestinal bleeding occurs because of splenic vein thrombosis. Then we'll be getting into the details of this more when we talk about portal hypertension. Then, in case of renal involvement, you get acute kidney injury. Now, the acute kidney injury here could be due to a multitude of factors, which could be pre-renal AKI, which becomes intrinsic renal AKI. It could be renal artery thrombosis. It could be renal vein thrombosis because of the anatomical contiguity of these structures to the pancreas. And obviously, it could be simple, pre-renal AKI itself due to the third space volume loss and hypovolemia that has already been discussed. So you get an oliguric acute kidney injury. Uh, Fat necrosis typically doesn't cause embolization to the kidneys per se, but has been reported. Now, importantly, if the inflammation is very significant, diffuse endothelial activation can result in your disseminated intravascular coagulation. That can result in a bleeding diathesis, result complicating the clinical picture further. Okay. Now, coming to the second last portion of our discussion, that is some facts that are relevant to the clinical evaluation of pancreatitis. So, see, even though I've talked about SLE and vasculitis as and Sjogren syndrome as a cause of pancreatitis, actually only four causes are responsible for more than 95% of pancreatitis, acute pancreatitis. So, by far the most common cause is gallstones. The maximum risk of gallstone-related pancreatitis is when the stone is actually very small, because those are the stones that can actually leave the gallbladder. So if the stone size is less than 4 millimeter, there is a 4 times elevated risk compared to if the size is larger than or equal to 5 millimeter. Uh, the second most common cause is alcohol, that is ethanol use. Uh, the incidence of alcohol consumption related pancreatitis is about 5 per 1 lakh population, and at least some older data suggests that there is a dose dependent relationship with smoking in patients who are taking alcohol. Okay, there is no per se dose dependent relationship with alcohol like you have in say cirrhosis. However, the acute amount of alcohol ingested, that is the particular binge, may be related to the likelihood of developing pancreatitis. Then we have so the risk factors for alcohol consumption related pancreatitis, like I said, there is an increase with concomitant smoking. The third, and by far by a significant margin, the third most common cause is hypertriglyceridemia, which is around 4% of cases. Now, most cases of hypertriglyceridemia related pancreatitis are related to are secondary to your alcohol consumption itself, or they are secondary to OCP usage. So this is a very specific subset of patients, or obviously insulin resistance in patients with diabetes. And then that situation, the pancreatitis itself can induce diabetic ketoacidosis, and this is a classic clinical scenario in which you have a presentation of a patient who is a known diabetic who develops diabetic ketoacidosis. Uh, Usually type 2 diabetes later on in the course of disease, and there is say there, like we've discussed, the presentation is with acute pancreatitis, and because DKA, as we've discussed, is a cause of diffuse abdominal pain, there can be confusion regarding the presence or absence of underlying pancreatitis. Okay. Then the fourth most common cause, again by a significant, that is only 2% of cases, is drugs. And the drugs that cause pancreatitis, I remember using the mnemonic move fast. So in this situation, it's M stands for 6-mercaptopurine. Naturally, that includes azathioprine. O stands for OCPs, as we've discussed, that increases the risk that can cause hypertriglyceridemia also, and that can cause pancreatitis. Then V stands for valproic acid. E stands for naturally estrogen containing pills and things like that. Then F stands for furosemide. A stands for azathioprine. Uh, S stands for your sulfonamides, and T stands for thiazide diuretics. The T stands for tetracyclines. And the important thing is that, yeah, thiazide diuretics can cause it technically by causing hypertriglyceridemia. That is the important thing. So we've got your 6-mercaptopurine, oral contraceptive pills, valproic acid, estrogens, including OC pills, furosemide, again likely through hypertriglyceridemia, azathioprine, very importantly, sulfonamides and tetracyclines. Okay. Now, see the exact values quoted in Harrison's, the 22nd edition of Harrison's Principle of Internal Medicine are for gallstone is 30 to 60%. For ethanol, it is around 15 to 30%. For high triglyceride values, it is 1.3 to 3.8%. And for drugs, it is only 1.1 to 2%. So, however, the most common cause, fast as a one-liner, is a combination of gallstone plus ethanol-related pancreatitis. Okay. Now, see, because the diagnosis of pancreatitis can be made without any radiology, just based on the classic abdominal pain of a patient and the presence of elevated serum amylase or lipase levels more than 3 times the upper normal limit, we need to know what are the causes of false elevations in serum amylase levels. Lipase is very specific, so see elevations in lipase levels don't really have any false positives. However, elevations in amylase levels have significant false positives. So, there are abdominal causes in which the patient would have some form of abdominal pain also, and that would cause further confusion. And then there are extra abdominal causes. So, among the abdominal causes, the first cause that is there, that is, I remember it using A, B, C, D, E. So, the first cause is abdominal aortic aneurysm. Importantly, see, aortic aneurysm pain would also have many of the clinical features of acute pancreatitis. It's just that the descriptor that the patient often uses is a tearing pain, okay, rather than a boring or a severe dull aching pain. That is the only usual differential. But again, the amylase levels would not be that high. Second is biliary disease, and obviously biliary disease can coexist with pancreatitis. So you could have, you could have any type of biliary inflammation and or obstruction due to stones, and that there may not actually be significant pancreatitis. So that causes some clinical confusion. Then we have a carcinoma of the head of the pancreas. Again, there could be just hyperamylasemia without any clinical or acute pancreatitis, and in that situation, see, often the patient will not have any abdominal pain. You would have just sent serum amylase levels and they'll just be elevated, and then you start thinking of pancreatitis. So there is a tendency to overcall pancreatitis in such situations. Then there is a diseased bowel. That is a perforation of the gastrointestinal tract or inflammation of the gastrointestinal tract. Very importantly, IBD. So as I discussed earlier, in cases of Crohn's disease, there are multiple causes of your pancreatitis, but also you can just have intestinal inflammation and an elevation in serum amylase levels that is responsible for the elevation, and that could be there, and there may no or not be actually any acute pancreatitis. And finally, we have E, that is ectopic pregnancy. Now, ectopic pregnancy is something that one must be very careful about, because again, history is the most important thing here. The pain that the patient experiences will be obviously pelvic, suprapubic, or in the right or left lower inguinal fossas. It will not be epigastric, and again, the complications of ectopic pregnancy, including shock, is something that you can have in pancreatitis also. So that causes some clinical confusion, especially if this history is not forthcoming. So that's something that needs assessment, that requires, you need to uh, take that into account. Now, uh, now the thing is that non abdominal causes also are there, and the thing with that is that often if you unnecessarily send amylase levels in patients for no reason, there is a strong possibility that it will be false positive. So it should be taken into account that it should not be sent unnecessarily. Only in patients with some significant pretest probability of pancreatitis should you send serum amylase levels. So one cause is obviously a decrease in GFR. This could be any type of AKI or CKD. So CKD patients, be careful about considering pancreatitis. Then there is opioid use. Obviously, opioid related narcotic bowel syndrome, and narcotic abdominal pain syndromes. Um, can also present with central abdominal pain, and we've discussed the clinical presentation of that. So again, without taking a proper history, if you send serum amylase levels, you'll get a false positive. Then there can be trauma, and like I said, trauma can cause pancreatitis. Trauma can itself just cause hyperamylasemia and burns. So these are two situations where clinically pancreatitis can be overcalled. So you need to be a little careful about that. Then there is macroamylasemia, in which the patient always has an elevated serum amylase levels, resulting in 4% around so false positivity in around 2 to 4% of the population. Then some carcinomas, because they are adenocarcinomas, also cause release of your amylase enzymes into the blood. So that remember using the mnemonic lobe. Okay, because they are adenocarcinoma, so they arise from acini or lobes. That is L for lung carcinoma, O for ovarian carcinoma, B for breast carcinoma, and E for esophageal carcinoma. Okay, so macroamylesema is something that everybody would recall. If you know about it, you know about it. Uh, these lobe or the four malignancies that result in this can be easily remembered. And then something that we must be very careful about is CKD and your opioid related causes. Now, finally, coming to post ERCP pancreatitis. Now, this is relevant to us only because often the ERCP is done for the evaluation of other medical disorders. For example, primary sclerosing cholangitis, although that's not commonly done. Okay, and or patient who's being evaluated for IgG for related disease, and then the patient develops pancreatitis, and we don't really know whether it is due to ERCP or that is uh, ERCP would stand for endoscopic retrograde cholangiopancreatography. That is basically, cannulate the pancreatic duct and the distal CBD and inject dye into it. So that process results in pancreatic duct obstruction and pancreatitis in about 10% of cases. And this kind of pancreatitis develops in very specific patients. So what are the risk factors that are related to this? So the risk factors are divided into patient-related risk factors and procedure-related risk factors. Patient-related risk factors include age of the patient less than 60 years. That is a younger patient. That's very important. Okay. Possibly because the smooth muscle in the sphincter, as you can relate the sphincter, is hyperactive in in younger people, and the size is smaller. Then second thing is any dysfunction of the sphincter of OD. The third is a prior history of post ERCP pancreatitis. This is actually the strongest single risk factor in most studies. Then we have during the procedure, if you perform a minor papilla sphincterotomy, because the minor papilla forms a parallel pathway through which the pancreatic secretions can drain in case the primary papilla is obstructed during ERCP, and obviously a inexperienced performer of ERCP. So most experienced gastroenterologists usually have much lower rates of ERCP related pancreatitis. So in patients who do not have these risk factors, one must be very, careful about over-calling ERCP related pancreatitis, and in the correct clinical context, one should be aware. Okay, so this particularly becomes relevant when you have a, systemic autoimmune rheumatic disease that can, that can itself contribute to pancreatitis. Like I said, SLE, Sjogren's syndrome, IBD, vasculitis. So in certain situations, it becomes very relevant. Okay, so that brings us to the end of this discussion. So what we've discussed is we've understood the pathomechanisms underlying acute pancreatitis, particularly the central role of intrapancreatic enzyme activation. And we've understood the three common pathways that result in such activation, namely direct sinusoidal injury, abnormal co-localization of the trypsinogen containing vesicles with the lysosomal vesicles, and finally pancreatic ischemia. We've understood the three mechanisms that result in end organ damage, that is systemic inflammatory response due to increase in serum IL-6 levels, your hemorrhage because of release of elastase into the systemic circulation, and local release of elastase resulting in damage to blood vessels, causing splenic artery aneurysms, gastroduodenal artery aneurysms, and splenic vein thrombosis, and also, as we discussed, fat necrosis resulting in fat embolization and various clinical manifestations. We've deduced the etiologies that result in pancreatic inflammation. We both acute and acute recurrent, and we've understood the differences between the two. We've understood the different clinical presentation of pancreatitis related to end organ damage. This obviously, as we discussed, is due to systemic inflammatory response, due to vessel wall damage and secondary hemorrhage, and due to fat necrosis. And we'll be discussing how to call this on imaging in the next video. Then we become aware of some facts that that color the evaluation of acute pancreatitis. That is basically that more than 95% of pancreatitis are caused only by four causes, and of that, ethanol and gallstones constitute about 96% of, or rather 94% of even those cases. Okay, so these two are by far the most common cause. We've understood the other causes of serum amylase elevation. We've understood how other disorders that result in abdominal pain can also cause hyperamylasemia, and some systemic disorders which cause diffuse abdominal pain like CKD, and your narcotic bowel, that is opioid usage, can result in hyperamylasemia, and how four malignancies, that adenocarcinomas, can release serum amylase into the blood, causing elevation in serum amylase levels. Then finally, we've had a word about ERCP related pancreatitis. One thing I would also like to mention about ERCP related pancreatitis is that gastroenterologists often try to decrease the risk of ERCP related pancreatitis by giving per rectal NSAIDs prior to the procedure. That is just an additional clinical fact that I'm just mentioning. So that brings us to the end of this discussion, and I'll see you in the next discussion, where we'll be discussing imaging as a tool in the diagnosis of acute as well as recurrent pancreatitis, and as a tool in the diagnosis of the complications of acute pancreatitis. So thank you for watching. I'll see you next time.